there's too much, again, I know I keep saying it, too much complexity in the market to be good at everything. And so at some point, you just have to trust the experts.
Welcome to the Provider Engagement Podcast, where we talk with professionals in the healthcare industry about the changing landscape of value-based care and how payers and providers can improve those relationships and communication so that we can achieve the triple aim. And today we have with us a very special lady. She is a well-renowned speaker all across the national circuit, talking about that specific interlink between payers and providers. She has a long history in working both on the payer side and with providers, and has now become a vendor and a consultant, helping to improve those relationships all throughout the healthcare landscape. Dr. Shannon Decker, thank you very much for being with us here today on the Provider Engagement Podcast.
It's my pleasure, and I'm really excited to be here. So looking forward to the conversation.
So this is kind of a brand new revelation. A lot of folks that have seen you speak on stages throughout the country at all these different conferences are used to seeing the previous company that you were with tied to your name, and now they're going to see a different one. So why don't you tell us a little bit about that and where that transition came, and maybe kind of go back and tell us about that history you were telling us before, and kind of your whole evolution and career in healthcare.
Absolutely. I'll start at the beginning, but I promise it's been a long time, but I won't take that long. I got involved in healthcare more than 20 years ago with a large payer, and started working with them doing gap analyses, because my background had always been in learning theory and motivation, and so they wanted to understand how they could improve their messaging. And so from there, I was invited to get involved in this thing called risk adjustment, because they thought I might be good at it. No one really knew what it was, but they thought that they would give it to me and have a go at it. And at that time, I worked for a large payer. We had over 400,000 Medicare Advantage lives. It was a national plan, still in existence today. And I owned risk adjustment operations end to end, with two other folks on the team, but I was their operations manager, and really got an opportunity to see Medicare from the inside, as well as work on risk. From there, I went to work with provider groups, especially provider groups wanting to get into risk-bearing arrangements, and again, owning the risk adjustment relationship from end to end. In my last foray, I had the good privilege of really bringing it all together. And I know we talk about the triple aim, but I think the quadruple aim, how do you bring all the forces together to make sure that people are getting the right care at the right time, for the right price, in the right place, right? And so worked with provider groups, and then just had this realization that as CMS has really made it more available for provider groups to get into these risk-bearing arrangements. Doctors are great, super smart people, but sometimes some of the nuances of this contracting, and I've been in this business for over 20 years, it's how do you get to best practices quickly? And so in my new business, VBC1, so Value-Based Care 1, there's no mistaking what we do. It's helping provider groups understand risk-bearing arrangements, from reviewing contracts to making sure that they're represented well within the terms, to also setting up programs that are going to help them be successful. How do you measure ROI? Where do you invest? Developing your strategy really around what you have available. And then also, too, working with health plans. Smaller health plans, large ones too, but what are best practices? How do you make sure that you have the right foundation in place, that you're reaching out to patients and working with your physicians in a way that's meaningful? And then also too, working with vendors, helping to craft that message. I've been on the inside for a long time and have worked with varied groups. And so how do you talk to a CFO. What do you need to do to get across the messaging to show how your product, right, can be beneficial? And so really, I think that, as the conversation has widened, it's not only gotten broader, it's also brought more complexity and depth. And so there really needs to be someone that can help with that communication and help, bring the message across. And so that's what I'm doing now. And so really excited to be able to, to help people be successful. So thank you.
Well, and thank you. And I know that there are a lot of people that are very excited that you're kind of a free agent now and can help in ways a lot more intensely than just providing all the great insights that you shared from the stage and at conferences for a while now. So there's a lot of places to kind of unpack and to go with that. But, for us being focused on provider engagement, I think the first real big question I had that I wanted to get your insights and the from that background of just most recently kind of working on the provider side. Like you said, integrating, taking on risk, moving from fee-for-service to value-based care, it can be very intimidating. We've had several conversations with groups that are doing that, and just, like you said, very incredibly intelligent people, but just kind of lost in all of the different things that happen. But one of the other things that we've seen is, when people do get into that, now all of a sudden they're completely out of their comfort zone, because now they're having to deal with all this data and the things. So if you had, from the provider's perspective, one piece of advice to give back to payers on how to improve the reporting or the performance in terms of documentation submission or getting in compliance, submitting complete records, those type of things, what can payers do to really help the providers achieve that level in value-based care?
One of the things that I've noticed over the years is when we approach physicians, they're doing such important work. We talk to them like they don't know. And I think we really need to reframe the conversation. They know what they're doing. They're doing it already. It's just knowing and respecting what they do. And so I think sitting down and having a conversation and recognizing the value that they bring to it. Don't underestimate them. A lot of times we share these canned reports. We don't hear what they're telling us. I sit in many meetings where a health plan will be interviewing or wanting to tell us things about strategies, and it's all vanilla. And when I think about, like I said, with this business, it's just getting more complex. You need to recognize the strengths that are there. Don't spend a lot of time on those. You don't need to. They're already in place. And really focus on the things that need to be improved. And so rather than just giving a canned message month over month, and then really not moving things forward, sit down and pick one or two things that you want to focus on and have a real conversation and value the people that you're speaking with enough to really listen. And when I can't underscore that enough, really listen to what they have to say. We're not doing enough active listening in our industry.
Right, because it is and this is one of the things we do, right? When you actively listen, like it stirs up thoughts and maybe other questions about how to approach things. And that doesn't happen a lot, right? Because it's kind of this, the merger of these industries, or, when people think about like insurance, in general, there's had to be a big shift there too, because you're dealing with actuaries and accountants and numbers and, always super high efficiency processes, and like these worlds have kind of collided here. And so it's, when we had, a colleague, Dave Meyer, on, and one of the great analogies he spoke about was that, it's not baseball if nobody's catching, right? And so a lot of times health plans just look at, all right, here's this information, this is what we need, and we're going to deliver it in the most efficient way possible. And so it's like they're throwing all this data at the providers, but the providers aren't catching it. And so just what you say there of being able to focus, and it's not about efficiency. I mean, it really has to come back down to effectiveness.
Absolutely. You know what? Well, I was going to say, I want to dispel some myths, because every time I come into a new place, what a lot of times I hear is that, well, the providers just don't want to listen. The physicians don't want to listen. They don't care. It's not that they don't. It's just that you're overwhelming them. And again, you're not respecting them from the place that they come from. So I'll share with you, like, just some of the organizations that I've worked with in the past. I heard that message, and I've heard that actually at a few places where people are like, they're never going to listen. They don't have time. They're just not engaged. And then I went and talked to them, and I said to them, you know, how can I help you? And I think that that's a really important step. And it wasn't even help you. It was, tell me what's going on. You know, how are you feeling? And the messages that I heard, and I'll just share, and some of them are particular to context, so they might not be applicable to the entire industry, but would be things like, you know, they make me take this training class every year. It's the same stuff. I just sit there and I zone out. Or it's a PowerPoint deck full of codes that they ask me to memorize. Or, you know, you want me to do all this stuff and it just makes extra work for me. And one of the things that I did in the places that I went to is I said, okay, let me figure out how I can start where you're at. And I get it. You know, it might not be scalable, but I think we can talk about that. And I think that if we truly want to drive change, we need to not put up the wall and say, oh, you know, that's something we can't do because it's not scalable or it's not efficient. We're not asking for efficient, right? We're asking to be effective. And so we really need to frame it and think differently. And so when I would meet with these doctors and they would give me those messages, we changed the curriculum. We said, and that was probably one of the bigger projects that I did was, you know, looking at how the training was being done on documentation. And it really is education. And you think about it, you have very educated people that have gone to school for a very long time. They no longer learn in the way that a lot of us are accustomed to. We all think because we went to college or we got through high school that we are experts in education, and we're not. What we need to recognize is that physicians have worked at a different level, and there's actually something called andragogy, which is how you teach adults, versus pedagogy, which is how you teach children. And so we recrafted our curriculum to have different levels. You know, there are some people that need that beginning deck, but what about those that you want to move to another level, right? They're already relatively experts. And so how do you get them there, and how do you design? And really it becomes not a training, or it becomes a conversation. And these are people that love getting into that clinical back and forth, you know, that dialectic. And so how can we design trainings to be that way? Or not asking them to memorize codes, because, you know, think about when a doctor sees a patient, they're in the office, they have a certain way that they've been trained to think all their life. Why are we trying to impose upon them an unnatural way of thinking about the work that they're doing? Let them use what they're doing and find ways to insert what you want to get done in that office visit as well. You're more than likely going to have greater success. Other things that we did, working with docs too on documentation. You know, a lot of health plans like to give these pre-printed forms. Well, that just adds time. And when you're trying to, I think primary care especially is already stressed, right? They have to pay out so much money in insurance and see so many patients, and, you know, it's churn and burn. And then you're asking them to fill out this long form, and it doesn't really flow with what they're doing. And so meet them where they're at. Work with them to set up their EMR so that the templates are in. In about 30 minutes, you could set up the templates that you need in order to get the information that you're wanting from those visits. And it's a lot more efficient for everyone, and they're probably going to engage more than filling out some separate form. You know, how antiquated is that? No offense to those that use those, but to fill out some form and then fax it back and have someone read it. And there's just so many ways in my mind when I think of things could go wrong, information can be lost, that if you just made it more efficient and get it the first time around, right at that first step, from the primary source, the better off you're going to be.
We
So don't go make all the fax machine manufacturers mad. That's like the last market
They might
have.
not be calling me.
so just one question that I have for you, Shannon. We have noticed that part of mostly of this work is being done by supporting staff. Could be medical assistants or even office managers, and we know that they need also help. And something that we also have seen is that we potentially could use data to really tailor those conversations with the physicians. As you mentioned, physicians don't want to see a yearly PowerPoint or a quarterly PowerPoint when they probably already know, even the staff that is using it. So how do you see this data being able to help in kind of guide those conversations in the process?
I would say again, don't discount your audience, but think about how you might tailor it. How you're going to approach a physician, and think about the ultimate motivator, right? So physicians went to school to help people. Maybe they thought that they were getting a good salary, but really they went because they wanted to help people, and so appeal to that. When it comes to office staff, similar message, but perhaps slightly tweaked, and agree. These are the people that keep the business running and keep the doctor happy, but share that with them too. I definitely think that there's opportunities for incentives with our office staff, but help them, show them too how doing this work can help not only the practice be more beneficial, right? And then there's benefits around that can help them. But then also too, how you can improve efficiencies. If everybody wants people to be healthy. Everybody wants to be successful. Nobody wants to be told that they're not doing a good job. And so a lot of times, and this is something that I do too, is I'll go into groups and I'll talk to the support staff, be it at a vendor or in an office, and just say, look at the work that you're doing has so much more potential. We know healthcare is broken and there's a lot of opportunity, right, to fix things. And so one of the ways that we can do that is by seeing patients for their preventative visits. When you're talking with them and you're giving the message, share with them, how important it is for them to get their diabetic retinopathy screening. And I think sharing then with the office staff, right, the contributions that they're making, how good we feel. You don't always have to, and I know I'm digressing some, but we don't always have to appeal to, throw them cash. That doesn't motivate everyone. It definitely can help, but there's other capital on which we can rely. And so this idea of doing something for the welfare, right, of the greater good. And so sharing with them, the importance of making sure that Mrs. Smith gets in for her annual wellness exam could end up having, less of an impact financially on healthcare. You're getting her in sooner, you're making all these contributions, and I know that that's really powerful. I've had those conversations with teams, and they really feel like they're part of this larger cause, and I know that really motivates them and gets them excited. And so, I definitely think that, to coin a phrase, it takes a village. I think when you're going into provider offices and provider engagement, if you're only talking to the doctor, you're missing the mark. You really have to understand all the people that make that office run, and have that conversation with each person. You may need to tailor it, right? Because you have to think again about what motivates that group in particular, but you still need to have that conversation. And just to share too, I can't tell you how many times we've launched programs and someone would talk to the doctor and the doctor would be bought in, but then the patient would call in after we did a call campaign and the front office staff didn't know what was going on. And then they're like, we have no idea what you're talking about. Right there, it ends, right? So all the best of intentions fall flat. So definitely think, to your point about getting the office involved, a definite need for sure.
So there's a lot to dig into there, and I think we both share that background of being teachers in the public school system. So I appreciate the difference between pedagogy and andragogy. But the key part about the motivation and incentives is a really interesting concept for me too, around the idea around motivation, because obviously we deal in incentives and try to help make those plans a little bit more easier to administer and to communicate progress and things around that. And because, like you said, they are important and can really help. But we've seen in cases where our clients have come, it's like, oh, can you help us to do more incentives because we need to be a priority. There has been a need to get people to recognize that just because you have the biggest incentives, it doesn't mean that you're going to all of a sudden be now the favorite health plan that this independent provider is taking, right? There's a lot of other factors that go into that, and I think you kind of mentioned that. One of the things that we've mentioned before too is just like, how easy do you make this process? Because you have the biggest incentive in the world, but if it takes 5 hours of extra time over what somebody else does because they simplify the process, it doesn't matter. Like they're not, the opportunity cost, it seems to be too great. So beyond those financial incentives, beyond and then kind of the other side of the equation that you meant, kind of the more philosophical and alignment with culture, and then those other kind of intrinsic motivators. From a very practical standpoint, what are some of those kind of just logistical, not necessarily motivators, but things that smooth the process or remove the friction that make it easier for providers to engage with the whole value-based care process and documentation and all those requirements that are generally those sticking points that we hear about?
I think it's exactly what you said. I think, and I think it goes back to the comment too about you really have to understand who your audience is. It's just far too complex. I've used a lot of different motivation tactics in the past. Like I said, nobody wants to do badly, right? Nobody wants to fail. We didn't get into this so that we could feel bad about ourselves and say, hey, I did a terrible job today. And so everyone wants to be successful. And a lot of times, so when I go to a physician's office, we sit down and usually, the first reaction is, you're here to tell me how badly I'm doing or what I'm doing wrong. And I think that can't be the approach, right? Because they're not. And I think that's what they've heard from a lot of us. We're not talking the same message. And so I'll sit with them and I'll say, tell me how things are going. What are you doing? And listen first and pull out those things that are important, and then decide from there, to your point about, where the opportunity is, what's important to focus on. Because agree, no amount of money in the world, right? If I have to spend tons of time or frustrated to get something done, no amount of money is really going to pay for that. And so figure out where they're at, figure out where you can build from in order to make them successful. Sometimes just tweaking an EMR can be enough, right, to move them forward, to get them to do the work that they need to do. And then one of the things that I've found too is other types of recognition, right? It doesn't necessarily have to be money. And I think that when we throw money, not that money isn't important, I want to stick up for my doc friends who are doing all this hard work. But even though money is important, there's other ways in which you can reward. And so even providing, titles, awards. I've been part of groups where we really looked at how physicians were doing, and we would provide feedback. And we would look at other metrics too, not just, hey, your RAF scores this or this particular quality measure. There were lots of things that were put into it that identified, if you will, clinical performance and the types of behaviors that we were looking for. But then also too, we provided titles. So Associate Medical Director of Quality, right, or of Clinical Performance. And not only is it a win-win, right, the doctor's getting rewarded, they're getting this crystal plaque that we have for them, they're getting this title, but now you have a conduit, right? You have physician champions in the market that are connected with you, and you've built this channel to then also too look for people that you can use in the field that they even have a pathway, right? A career path into corporate culture. And so even things like that, I think, go a long way, and are some of the things, right? We can get creative with how we provide incentives. We just have to think again about what the motivation is of the individual.
I mean, that's probably for me, probably the one of the greatest pieces of advice, especially from the payer side, right? Like, incentives aren't just money. And as much as a financial history and background that a lot of those companies come from, we have to be more creative. I think that's awesome.
Well, and also too, I wanted to make a point about, and I talk about this a lot in my presentations. There's something called the zone of proximal development. You probably remember with Vygotsky, but essentially, I always think of it like a traffic light. If you ask people, if I said to you, and you're not a runner, and I said to you, you say you're a couch potato, and I said to you, I want you to run a marathon tomorrow, you're going to be like, no way. And a lot of times that's the message that we're giving to our physicians. We want you to go to 0 to 60 in 2 seconds, in addition to everything else that you're trying to manage. And it's too much, right? We just look at the task and we say it's just too daunting, it's too overwhelming. And so how can we break that down? And so again, thinking about where your audience is and then moving out from that space. I just think that you get more buy-in and more traction. If we practice over 4 months, if we eat the right meals, if we put in all the work that needs to go into it to get ready, you might be able to run that marathon, right, in 4 or 6 months. Depends on how bad of a couch potato you are. But I think we have to think the same way.
Might have to start with a walk.
That's right, 1 foot in front of the other. And then you look back and you see the distance that you've come. So...
No, that it's so true in many things, and I think if anybody hasn't seen you at Rise or some of the other conferences talking about, like, this is why, it's because you're bringing that educational, the behavior improvement, performance modification, all those kinds of perspectives that and motivation that we forget when you got one side that is generally focused on, I would say, actuarial things and numbers and accounting, and you've got another side that's focused on patient care, and then we're forgetting this whole human interaction and how do we actually change behavior or get people to adopt new practices and learn things. And the zone of proximal development, it's a huge concept for people just to be aware of, and everybody's roughly aware of it. They haven't heard it formally called that probably, but just like, what's right outside your comfort zone. If you can just get people to, and if people would go into conversations like, I'm going to understand where their comfort zone is and just ask them just to step right outside of that.
Absolutely.
And now all of a sudden we've expanded their comfort zone. And just, if you keep doing that, that can be a compounding process.
And I would say too.
I know John had another question.
Oh, go ahead.
Yeah, I have another.
But go ahead, finish your thought, Shannon, and then we'll let John ask his question.
No, I was going to say, a lot of people say, well, that's all well and good, Shannon, but is it scalable? And I think it is. I just think that, again, we can't think any longer about these universal once and done strategies, especially if, it's getting harder and harder to get results. And so we do need to be targeted and we do need to be specific. And so, again, to the analogy of one step, right? And one step leads to another step, and we look behind and we see the ground that we've covered. And I think we do the same thing, right? We look for physicians in our network, and we don't necessarily pick the one that's got the biggest practice or one that's the loudest at the, at the physician dinners, or the one that has the biggest reputation for what have you. Look for those that are well respected, that are strong within the organization, maybe those on the periphery. Get them to drink the Kool-Aid, work with them, approach them, and over time, you have this spread of ideas. And I know that it may not seem so tenable at first, but again, once you're there, you look back and you see the mountain that you've climbed, and you have more and more physicians engaged. And Personally, that's what I want, because that's the piece, right? That's dyed in the wool, that's indelible. You're going to have a great foundation. If you lose one person, you're not going to be crippled, right? Because you have a good foundation. You've kind of permeated it out. We should have learned something from COVID, not to make light of the experience we all went through, but it's kind of like, it's viral in spreading that message.
Well, and I get so aggravated sometimes when I hear people ask that question of, oh, is it scalable? That's totally the wrong question to ask. The question to ask is, how do we make it scalable? Because of course it is scalable. It might be ridiculously difficult right now, but that doesn't mean that we don't start, because it's going to get easier as we go, because we're going to be pushing our own zone of proximal development, right? And that's ultimately what is going to have to happen, is to be able to do that, because that's a core belief that we have, is that link between the health plans and the providers, like that's the biggest opportunity for improvement right now, because I don't care how much member engagement you have and how far we advance. At the end of the day, people would still rather pick up the phone and talk to their doctor than a call center in a health plan. Or if somebody from the health plan is going to call them, they're not going to trust it as much as if they get a call from the medical assistant at their doctor's office. And so we have to be able to bridge those gaps through all those things, and we have to find a way to make it scalable. But John.
Perfect. Yeah, you okay. So I see, Sharon, that you want to say something else. Is that, are you finished with your thought?
Well, I was just to piggyback on that, and then I promise I'll be quiet. There's been a huge push in healthcare of building these verticals. So we have a lot of health plans reaching down to the practices and buying them up. And I think that they look at certain organizations around the world and they think, hey, that's going to get us to where we need to be if we can just control, right, the people. But what I would argue against is that that's not going to get you there. It may look like it at the surface, but we have to be really careful. And I think about when we have those verticals, there's something called, and leaning back onto education, there's something called the hidden curriculum, right? And it's the things that we actually teach and then how it's manifested. And we have all these great plans in our schools today, but a student enters, they don't always come out the same. And I want to say the same thing happens with the verticals in healthcare. You can put a doctor in the process, but that doesn't mean that you're going to get the results that you're wanting or that you need. And so if you really want to get, true engagement, where they're doing the things, they're walking the walk, they're talking the talk, and they're doing the things that you want them to do, you really need to think about not being overpowering, but really working together and those synergies and coming along together. I think you're going to end up with the best results.
Good. So one of the questions that I have for you, Shannon, is, there is a lot of technology vendors out there and applications built being in-house by health plans, promising reducing costs or reduce the burden on providers or even patients, or the whole route. What do you see now that you were in both sides? What do you see that has been worked, or it is working at this point, and what do you think that is still a challenge that as a vendor you can approach and reduce those burdens to all the healthcare, specifically for providers?
So there was a time that I would have said to you, I can build it in-house, and I know what I need, and I can build it better. And I can tell you, I'm glad that I've grown up since then and recognize, it's too hard. There's too much, again, I know I keep saying it, too much complexity in the market to be good at everything. And so at some point, you just have to trust the experts. And so I think that while health plans are doing amazing stuff, sometimes you have to make sure that you stay in your lane. It doesn't mean that you don't get involved. It doesn't mean that you don't get into the weeds to a certain degree, right? You have to know your business. Somebody has to mind and mow the field. However, I think that if you have vendors, they can do things at scale. They can change things more quickly than what you can do in a health system. And what I've seen in some health systems that I've interacted with over the years is that they'll build a solution and then they can't keep up with it. And so it becomes, like I liken it to, I used to spend a lot of time overseas and working overseas and in certain areas of the world, and you would see where they would build structures basically on rebar, right? And the thing is that they would keep building higher and higher and higher, and as you built the tower, what would happen is the foundation started to crumble and was weak. And that's how I think about these systems, is that we'll build stuff and they're great out of the gate, right? These ragtag fleet systems, but over time, they're just impossible to manage. You can't build on them. You change out code, it wrecks something somewhere else, then you've got another problem. And so I think looking at the right solutions, managing them well. Again, we can't rest on our laurels. We can't get lazy. Buy the right tool, manage it well, and I think that you'll be far more successful. And so I'm glad I've come away from those days of where I thought I could do it all, and now it's trust in some really good partners that do it better, and will always do it better because they're able to make the changes. That's what they're invested in, right? We can't be great at everything. There's a reason why there's specialties in medicine. There's a reason why there's specialties among vendors too.
Excellent. Good to hear. And as you mentioned, Medicare is incentivizing providers to take more risk directly into this process. And as you probably know, there are a lot of health plans that they can count off. Every health plan providing their best knowledge and passing that to providers. So from that perspective, how do you see the transition of these small providers having to acquire these tools to be able to be successful managing risk?
Well, I think a couple of things. So provider groups, right, aren't just interacting with one health plan. They have many. And so they're trying to bring all that information together. And to me, for the sake of efficiency, I would find solutions that would help me bring all that information together across my patient panel. And then look for commonalities, right, across contracts of what I could focus on. Now with providers, it's not just about interacting with health plans. Providers themselves can contract directly with CMS and offer benefits. And some of the larger groups are doing this. And what I would say with that too, I would put caution out there to, make sure that, again, you have the right foundation in place to do this well. And I think the best way to do that is to not be so fragmented and look for ways, and again, make sense, right? Be efficient, bring the information together, but don't let efficiency run away with the authenticity, right, and the specification that you need in working, in doing your best work.
I think that's great advice, and it's an excellent segue into maybe kind of the capstone question for this whole conversation. And as you just alluded to, more and more opportunities for providers to move to value-based care are coming open now, being able to go directly to CMS. But even if they're not looking at that big of a leap, right, and just taking on risk or capitated contracts with health plans and moving into more value-based rather than fee-for-service models, what would you say are kind of the biggest considerations, or maybe I just ask for your best piece of advice for a provider group that is looking to make that switch? What are the most important things that they need to consider?
I think look at the contract, look at what you're being asked to do, and make sure that it's something that you can do, right? Be honest with yourself. Don't commit to a particular, not that we don't have to get there, but don't commit to certain scores on a CAP survey if you have nothing in place to support that, right? One of the things that I always, and I think we've been talking about this whole time too, right, is around know what your strengths are and don't boil the ocean. Choose 1, 2, maybe 3 things to start out with. Get really good at that and then build on it. And make sure, again, that it's something that you can measure. If you can't measure it, you can't manage it. And so make sure that you can measure it. Make sure that it's something that you want to focus on, can focus on. And again, that one baby step is another step, that eventually you'll look back and you'll see how far you've come. But that's how I personally would start.
Excellent.
Well, that's pretty fantastic advice. And so I hope that everyone has enjoyed this episode of the Provider Engagement Podcast. And we'll follow up in the show notes, connect with Shannon so you can ask her for even more of her insights. But just be aware, she's charging by the hour now. So with that, we'll sign off and see you on the next episode. Be well.